Hello, doctors. Today we are going to study the principles of preventive, promotive, and lifestyle medicine. And so today we'll discuss and how we can apply them in everyday practice in our OPD versus IPD practice. So first, we'll go forward with the overview of preventive medicine. So let's begin with the levels of prevention. So this is like a backbone of the public health thinking. First is primordial prevention. We act on social, economic, environmental determinants to prevent any kind of risk factors from appearing. For example, policies that reduce salt in processed foods or creating walkable cities and all. Second is primary prevention. So primary prevention is stop disease before it occurs, like we can do smoking cessation, immunization, and healthy diet counseling. Third is secondary prevention. So secondary prevention is like an early detection, like a screening test such as BP measurement, fasting glucose, and pap smears to catch any disease early and treat it accordingly. Fourth is tertiary. Tertiary prevention reduces the disability from established disease, like rehabilitation, counseling, and complication prevention in the chronic disease. So, in family practice, we operate across all the four levels, that is primordial, primary, secondary, and tertiary. So, from community advice, that is the primordial, to chronic disease follow up, that is the tertiary. So, this is what the overview of preventive medicine. Next is the promotive health concepts. Promotive health goes beyond preventing disease. So it actively improves the well being. So this means structured health education, individualized lifestyle planning, and community engagement. And practically, this looks like a group education for pregnant women, workplace stress reduction sessions, or school nutrition programs, etc. So promotive work is often like a low cost with high yield because it shifts the whole population's risk. And we also have to encourage the patients or the community for healthy habits. So identify one small change. For example, like if the patient comes to you, when you take the history you'll come to know about the patients. For example, you can swap the sugar sweetened drinks for water and write a one line prescription that the patient can follow. So this keeps an advice practical and acceptable. So that is about the promotive health concepts. Next is the key modifiable risk factors. So, key modifiable risk factors, the most chronic disease burden comes from a short list of modifiable risk factors like physical inactivity, unhealthy diet, smoking, harmful alcohol use, poor sleep, and chronic stress, obesity, and metabolic risk like hypertension, diabetes, and dyslipidemia. So these are like an interlinked. For example, obesity increases the risk of hypertension and diabetes, and stress can worsen the sleep and eating patterns of the individual. So always screen for these. Ask the patient or ask the individual about their physical activity, diet, and any tobacco usage, alcohol, and about their sleep routine. So a single question can pick up the risk for most of the conditions. So that is about the key modifiable risk factors. Coming to the nutrition principles in the family practice. So, nutrition counseling must be brief, practical, and tailored. So, use like a palette method. Palette method, like you can also say plate method. Half the plate of vegetables and fruits, a quarter whole grains or starchy staple, a quarter portion of protein, prefer a plant based where possible. Advise the patient for reducing salt, removing the trans fats, limiting the refined sugar and processed foods, and increasing the fiber content of the eating diet food. So for specific conditions, for diabetes, ask the patient for emphasize the carbohydrate quality. For hypertension, stress salt reduction is good, and potassium rich foods. And for CKD, restrict the protein and potassium as per the stage. So this is like you can advise the patient in a simple manner. So in such conditions where you can swap the white rice for brown grains twice a week, add one extra vegetable serving daily, and avoid the packaged snacks. So give one concrete goal which can go with the patient's condition. So that's about the nutrition principle and the family practice. Next is the exercise prescription. So make exercise a prescription, not like a general advice. For most adults, 150 minutes of moderate intensity aerobic activity weekly is advisable, or 75 minutes of vigorous activity plus strength training 2 times per week. So this is how you can prescribe it. So for sedentary lifestyle or obese patients, start with the achievable goals like 10 to 15 minutes of brisk walk daily and increase gradually. And for older elder adults, include the balance and strength work to reduce the fall risk. So these all things you have to prescribe to the patient rather than like a general advice. You can also do a safety check before exercise, screen them for any chest pain, uncontrolled hypertension, recent any syncope or severe breathlessness, and if present, do a pre-exercise evaluation and an ECG if indicated. So like this you can prescribe the to the patient. Exercise is also important rather than in a verbal way. You can prescribe in your OPD. Next is the mental health and stress management. So, mental health is like central to lifestyle medicine. Screen routinely with PHQ-9G or for depression and G87 for anxiety when you suspect any kind of symptoms. Teach a simple evidence-based things sleep hygiene, regular sleep schedule, no screens before bedtime, relaxation breathing, brief behavioral activation, and problem solving steps and all. So for moderate to severe cases or any kind of suicide risk, arrange an urgent psychiatrical reference. So there are few red flags also for referral, like suicidal ideation, psychosis, inability to maintain daily activities, or severe substance dependence. So in OPD, small interventions like a 5-minute breathing exercise demonstration can have an immediate benefits. So these are the things you can do for a mental health and stress management. Next is the preventive health screening. So, screening is the early detection arm of prevention. Like core screens in family practice, at example, a BP measurement at every visit, fasting glucose or HbA1c when risk factors present or age is above 40, and a lipid profile every 3 to 5 years, depending on the risk. You can do the screening for cancer screening. Follow the national point levels like cervical screening, PAP or HPV, breast screening with clinical examination, mammography per local guidelines. And don't forget the immunizations like influenza annually for high risk group, adult tetanus boosters, and pneumonia vaccines based on the age and any comorbidity. So how to prioritize like if resources are limited, screen the highest risk patient first, those with obesity, family history, or multiple metabolic risk factors. So you have to prioritize accordingly to this. Next is the OPD management. So OPD management, in OPD we do most of the preventive work. So start with the risk assessment like record BP, BMI, waist circumference, and order the lab like FBS, HbA1c, lipid profile, creatinine, urine albumin as indicated, and use a motivational interviewing like ask permission, set a small goals, and provide a return lifestyle prescription. For example, prescription you can write diet, reduce sugar, follow the plate method, exercise 20 to 30 minutes brisk walk, then sleep 7 to 8 hours. Look, so you can write it accordingly. So a prescription should be like that. It's not like a verbal thing. In prescription you have to mention all the advising things. Next is the IPD perspective. So, some patients require inpatient care. For example, hypertensive emergencies, acute coronary syndromes, acute stroke, or DKA, then severe hyperglycemia, or severe psychiatric crisis. So, in such cases, you have to admit the patient. In IPD, our focus is stabilizing the patient, and you have to address the immediate complication like IV management, monitoring, and starting a guideline based therapies and all. Importantly, IPD admission is an opportunity opportunity for a lifestyle counseling before discharge. So, a structured plan, referral to cardiac rehab or diabetic educator, or clear follow up appointments is required. Even in the discharge summary also, you have to mention all the things accordingly about the medications, the diet, lifestyles, and about the follow up, etc. So, summary of today's session, to summarize, prevention and promotive medicine reduces the disease burden and are very core to the family practice. Lifestyle medicine is which includes nutrition, exercise, sleep, and mental well-being must be a part of every visit of the patient. OPD is our main area for behavior change using short, practical prescriptions, regular follow-up. IPT management focuses on stabilization and transition to structured outpatient lifestyle programs. So start small, be specific about the diagnosis and things, and follow up. So prevention is better than the cure. So this is the things about today's session. So what we have discussed today, I hope you got a clear idea of what is preventive, promotive, and lifestyle medicine importance in the family practice. So that's it for today. Thank you for patient listening and have a nice day.